Good day and welcome to the continuation of our discussion on fluids, electrolytes, and acid-base balance. As a disclaimer, this lecture is intended for Level 3 students of the Bachelor of Science in Nursing program. This material is mainly referenced from Brunner and Suddarth textbook of Medical Surgical Nursing. This lecture does not constitute medical advice, and parts of the discussion may not be suitable for the general public. If there are any concerns regarding this presentation, the email is presented on this slide. For this lecture, our focus is calcium. We'll be talking about calcium imbalances, which is your hypocalcemia and hypercalcemia. Now, we need to remember that the body's calcium is considered to be a divalent cation. It has two positive charges. 99% of our calcium is stored in our skeleton. This is the inactive form of our calcium. Calcium has several functions in the body. Other than maintaining the bone strength, it also is used to activate enzymes, transmit nerve impulses, also helps in the regulation of your muscles. That would include your skeletal and cardiac muscle contractions, and then your blood clotting or blood coagulation. The normal amount of calcium is at 8.6 to 10.2 milligram per deciliter or 2.2 to 2.6 millimole per liter. There are three forms of calcium. One is your ionized calcium. Ionized calcium, although less than 1%, is considered to be the active form of calcium and should be regulated properly in the ECF for proper functioning. On the other hand, your bound calcium is bounded to a special protein or protein you refer to as albumin. These are considered to be inactive forms of calcium. Complex calciums are those that are bounded to special anions, such as your phosphate, citrate, and carbonate. This diagram reminds us that there are two hormones that would act on blood calcium levels. One is your parathyroid hormone, and then the other one is calcitonin. Please be mindful that your calcitonin is produced by your thyroid gland, whereas your PTH or your parathyroid hormone is also produced by your parathyroid gland. Now, whenever there is a decrease in serum calcium, PTH would be increased. Your parathyroid gland would release the parathyroid hormone to increase the PTH. What will be the role of PTH? The main goal of PTH here is to increase serum calcium. And to increase the serum calcium, PTH will be increasing the calcium reabsorption from the kidney. So when I say calcium reabsorption, instead of the calcium going out of the kidney, your PTH will try to get hold of the calcium so that it will be returned in the body. Also, there will be increase in bone resorption. When I talk about bone resorption, it is wise for you to remember that it is the osteoclastic activity that take over in bone resorption. So when I say osteoclast, these are cells that destroys the bone. Okay, so in order for PTH to increase the blood calcium levels, it needs to get calcium. And the best source of calcium for your PTH will be your bone. Okay, then once PTH has taken effect and then calcium levels has already increased, okay, it's high normal, already normal, your thyroid gland will trigger the release of calcitonin. And it will be calcitonin that will stop the function of your parathyroid hormone. It will inhibit calcium reabsorption from the bone and decreases the serum concentration by increasing your kidney's excretion of calcium. So again, this is an example of your negative feedback mechanism. Once calcium is decreased, parathyroid hormone will take over. Once your calcium is already increased, it is your calcitonin that would take over. This is to ensure homeostasis in our body functioning. Now, we'll be discussing hypocalcemia. There are several risk factors for hypocalcemia, common among older adults and persons with disability. But take note, the usual misconception is that if you have osteoporosis, you'll also have hypocalcemia. Take note that in osteoporosis, it is the general or total calcium in the body which is decreased. But it is still possible that patients with osteoporosis would have normal blood calcium levels. Okay, so it does not follow. Now, what is the effect of bed rest in bone resorption? We expect that bone resorption will be increased because of bed rest. That's why your patient who have been on bed rest for long is also at risk of hypocalcemia. Now, there are different kinds of causes for your hypocalcemia. One is your primary or surgical hypoparathyroidism. When I say primary hypoparathyroidism, meaning there is a problem on the parathyroid hormone or the parathyroid gland itself. there is a primary problem from the parathyroid gland. When I say surgical hypoparathyroidism, this can be usually seen among patients who have had thyroidectomy. So what happens in thyroidectomy? There is accidental removal or accidental dislodgement or accidental injury towards your parathyroid gland. And because of this injury towards your parathyroid gland, the parathyroid hormone function will not be properly practiced. Now, the same for your radical neck dissection. There is a very big tendency that the parathyroid hormone will be touched during surgery. Massive administration of citrate blooded or citrated blood. Citrate class is the substance that is used to preserve blood, okay, after your phlebotomy, before your blood transfusion. So for the blood to stay in the refrigerators, it needs to have potassium citrate or citrate itself. Now, the problem with citrate is that it binds with ionized calcium. It binds with ionized calcium. Once it binds with ionized calcium, the total amount of calcium in the body or the total amount of calcium in the serum may decrease, hence leading to hypocalcemia. Now, pancreatitis. In pancreatitis, it causes breakdown of protein and lipids. So remember that calcium combined with fatty acids release by lipolysis, hence forming soap and then later on causing hypocalcemia. So take note of that. Okay, in pancreatitis, there is a breakdown of protein and lipids. And because of this, your calcium would combine with the lipids, leading to hypocalcemia. Other than that, okay, you also have your glucagon. Extensive secretion or excessive secretion of your glucagon from an inflamed pancreas, okay, might result to increased secretion of calcitonin. Okay, there might be increased secretion of your calcitonin. So what will calcitonin do? Your calcitonin will try to reduce your blood calcium levels. On the other hand, patients with kidney injury frequently have serum phosphate levels which are elevated. With that, there is a compensatory or there is a reciprocal drop of your serum calcium. Take note that calcium and phosphate are not friends. So whenever there is an increase in the phosphate levels, the calcium levels tend to be decreased. Okay? Then, other purposes or other reasons for your calcium problem or hypocalcemia. One could be inadequate vitamin D consumption. Remember that for your calcium to be properly absorbed by the body, it needs vitamin D. So intake of calcium is not enough. You need to couple it with vitamin D. Magnesium deficiency may also cause that. Okay, so when I say magnesium deficiency, just take note that calcium and magnesium are friends. So whatever happens to calcium, the same thing happens to magnesium. Then you might have medullary thyroid carcinoma. Then you may also have low serum albumin levels, alkalosis, alcohol abuse, and then medications. There are medications class that can cause your hypocalcemia. Example of these medications are your aluminum containing antacids. Also, you can have your aminoglycosides. Also, remember mithramycin. So, these medications can cause hypocalcemia. Other than that, you have your kidney injury. Okay, for your kidney injury, just remember that whenever the kidney is injured, phosphate will not be excreted properly, and the tendency of the body is to have hyperphosphatemia. So in return, what happens to calcium, because they are not friends, so calcium would be decreased. Okay? Let us discuss the clinical manifestations. The first one is tetany. Your tetany is characteristic of hypocalcemia and hypomagnesemia. This is because of neural excitability. Vostok sign. Vostok sign is elicited by tapping anterior to your ear. You're tapping the facial nerve here. By the time you tap the facial nerve and your patient would have hypocalcemia, there will be twitching of the facial muscles. You also have trousseau sign, which is elicited by placing the beepic cuff at about 20 millimeter mercury above the systolic blood pressure. And this would cause carpopedal spasms. That's for your trousseau sign. Seizures. Seizures also brought about by neural excitability. The same with your mental changes. For the ECG, prolonged QT and prolonged ST is expected. In the long run, if not managed, the condition referred to as torsade de poids would occur. So torsade de poids is a special ECG abnormality which is manifested by polymorphic ventricular tachycardia. So there is too fast heart rate, and then the ventricular tachycardia tends to be polymorphic, meaning there are different shapes of QRS complex that is visible in the ECG. This is a life-threatening ECG that can possibly lead to cardiac arrest. Then you have dyspnea and laryngospasm. Laryngospasm is also an emergency because it can alter the airway of our patient. Other clinical manifestations may be related to osteoporosis, which may be brought about by a low intake of calcium or a total deficit of calcium. You would expect that there is loss of bone mass, bone mineral density would be decreased, and then there will be signs and symptoms of hyperactive bowel sounds, dry and brittle hairs and nail, and then abnormal clotting, which are signs and symptoms of chronic hypocalcemia. So among patients with osteoporosis, chronic hypocalcemia is expected. On your left, that's a demonstration of your Vostek sign. On your right is your Trousseau sign. Now, assessment and diagnostic findings. Of course, you'll be looking at serum calcium to check if it's really low, and then you need to check for serum albumin. For the serum albumin, you need to know that, okay, serum calcium needs to be corrected if the serum level is too low, because the tendency if the albumin level is too low, the calcium level is underestimated. Okay, there is underestimation of your calcium level once the albumin level is low. And then you also need to take the arterial pH. Now, what is the emergency management? Remember that our problem is calcium, hypocalcemia. There is a lack of calcium. Hence, we will be giving calcium to our patient. That will be in the form of calcium gluconate and calcium chloride. What are the precautions that we need to take note of? One is digitalis toxicity. Your calcium plus digitalis, higher risk for toxicity, because it's because your calcium also mimics the action of your digitalis. Then infiltration. If there is an infiltration of the IV site, the IV site needs to be replaced. Also, please take note that when you are administering calcium, you are not supposed to add plain NSS to it, because your plain NSS increases renal calcium loss. So the best solvent that will come with your calcium gluconate is your D5 water. Okay, D5 water. Postural hypotension may also occur along with your blood pressure changes. Bradycardia leading towards arrest is possible. That's why for these patients, the administration of your calcium gluconate should be diluted. Okay, slow IVTT using your pump or using your infusion pump to ensure the safety of the patient. Oftentimes, we would even attach our patient to a cardiac monitor for close monitoring of the ECG, because if this medication is pushed too fast, the heart may be stopped. Okay, the heart may stop, which is a complication that we don't want to happen. So there's a high risk of arrest in your calcium administration. So you have the following, no? When you're administering calcium, this slide reminds us that we should have the cardiac monitor to closely monitor for ECG changes. And then also note that calcium gluconate is a high alert medication, meaning you need another nurse to be counter checking on your calcium gluconate that you have prepared. And then on your right, that is your infusion pump. Management for our patient, we would have your vitamin D. Take note that for the body to absorb calcium, it needs to have the active form of vitamin D. Now you have the terms there: aluminum hydroxide, calcium acetate, and calcium carbonate. These chemicals can neutralize your phosphate levels, because for calcium to be corrected, the phosphate level should be corrected first. Okay, so the purpose is to decrease elevated phosphorus levels before hypocalcemia would be treated. And this would be apparent if your patient would have kidney problems. And then increase calcium intake at about 1,000 to 1,500 milligrams per day. Okay, and then that would include food sources such as milk products. Then you have your green leafy vegetables, and then your canned salmon, sardines, and fresh oysters, which are all rich in calcium. For our patient with hypocalcemia, seizure precaution is among our first priority. So when I say seizure precaution, the The side rail should be padded. Side rail should always be up for safety. Call bell should be within reach. The bed should be in the lowest position. Then you need to have your suction catheter and suction machine to be on standby at the bedside along with your oxygen supply. Okay, then you will have airway alert. Remember, the patient will be at risk for laryngospasm. Other than that, so you need to stand by again your oxygen and suction at the bedside. Also, you need to have your emergency drugs for your patient. Alcohol and caffeine inhibit calcium absorption, hence they are strongly contraindicated during the admission of your patient. Cigarette smoking would increase urinary calcium excretion. So meaning if patient is continuously smoking, there will be no benefit on the supplements that you're taking. Laxatives and antacids contain phosphorus. Take note of that. The next topic is hypercalcemia. Causes for hypercalcemia. One is malignant tumor. This tumor may increase the amount of your parathyroid hormone. As discussed, second is hyperparathyroidism. So in your hyperparathyroidism, there is also an increase of your parathyroid hormone. If you can recall, once parathyroid hormone is increased, there will be increase in calcium levels. The same thing happens in vitamin A and D intoxication. Chronic lithium use and theophylline toxicity. Immobilization. For your immobilization increases bone resorption. So when I say bone resorption, it is the activity of your osteoclast. And osteoclast is the cell in charge for bone breakdown. So if there is increase in the activity of the osteoclast towards your bone, the tendency is for the bone to be slowly broken. Okay, and once bone is broken, okay, or metabolized, it is being released to your bloodstream. Calcium is being released to your bloodstream, hence making the bone weak but increasing the levels of your calcium in your system. Then thiazide diuretics. Thiazide is known to potentiate your PTH effect. So it potentiates your parathyroid hormone, thus increasing also calcium levels in the blood. Now, remember that the relationship between calcium and phosphate or phosphorus are opposite. So whenever there is an increase of calcium, we expect phosphorus also or phosphate to be decreased. Now, one effect of your hypercalcemia is reduction of your neuromuscular excitability. So if there is a reduction of neuromuscular excitability, we are looking into the complication of hypercalcemia to be towards confusion, and then in the longer time, okay, or in the longer span, would result to lethargy, confusion, okay, stuporous, and then later on the patient might undergo coma. So unlike your hypocalcemia, the manifestations of hypocalcemia are towards neuromuscular excitability. For hypercalcemia, the inclination is towards coma. Now, decreased muscle tone would be there. That would be including your smooth and striated muscles. Then you have muscle weakness and incoordination, anorexia, and constipation. Cardiac effects will also be dominant in our patient. So clinical manifestations, we have severe thirst. You also have polyuria. In an attempt of your body to excrete the excess calcium, polyuria would occur. Then you have muscle weakness, intractable nausea. Then you have abdominal cramps, severe constipation. Remember calcium. Then you might have diarrhea in some cases, peptic ulcer symptoms, bone pain, which is brought about by the destruction of your bones, okay, destruction, quote unquote, and then other than that, there is a possibility of presence of malignant tumor towards your bone. If there is a tumor in your bone, this tumor may also cause your bone breakdown. Then as mentioned, lethargy, confusion, and coma towards neurodepression. Then, other signs and symptoms are variety of dysrhythmia, but we are expecting the shortening of your QT interval and your ST segment. Earlier in hypocalcemia, you can recall that QT interval and the ST segment are prolonged. For this condition, hypercalcemia is expected to be shortened. Then you have prolonged PR interval in that case. Then you would have your double antibody PTH test. The purpose of your double antibody PTH test is to differentiate between primary hyperparathyroidism and malignancy. Okay, which one of these causes hypercalcemia? So you need to do your double antibody PTH test. Then your x-ray is used to detect bone changes. Maybe you can see bone changes there because of tumors, maybe cavitation, maybe osteoporosis for that matter. Then you would have x-ray, urine calcium for your patient. As mentioned, your body would try to excrete the excess calcium in the body. Hence, there might be an increase in urine calcium levels. That is if the kidney still functions. Then medical management. If it is a tumor, chemotherapy is needed. If it is regarding your parathormone functioning, a partial parathyroidectomy may be needed. Fluids is given because if calcium levels are increased in the blood for prolonged periods of time, your patient will be at risk for formation of stones and other complications. Other than that, the fluids will help to excrete the excess calcium. Okay, ambulation. Ambulation is expected to reduce your bone resorption. So if the patient with hyperkalemia will be moving around, the calcium will go back to the bone and the calcium will be stored again in the bone. That's why ambulation would surely benefit our patient. Plain NSS is given. Since we know that calcium and phosphate are enemies, okay, now this time hypercalcemia, you can give your phosphate. Then furosemide is given to excrete excess in calcium. Okay, then you have calcitonin. Remember, there are artificial forms of calcitonin. And when I say calcitonin, it has an antagonistic effect on the levels of calcium. Remember, PTH increases calcium. Whenever calcium is already high, it will be calcitonin, which is produced by your thyroid gland that will take over. Okay, calcitonin may be given intramuscularly, and then if ever you'll be using the salmon calcitonin, you need to do skin testing because remember, salmon, it's a seafood. Okay, there's a lot of patient allergic to that. Then, if you don't have choices, if it is a tumor, then surgery, chemotherapy, radiation therapy. Chemo and radiation and surgery are mainstay treatment in cancer, so they need to be done. Okay, they need to be done in order for the tumor to be adequately managed. Then corticosteroids may be given as needed. Okay, biphosphonates. Your biphosphonates is expected to reduce your osteoclastic activity. Hence, it would allow the bone, okay, it would allow bone reabsorption, decrease on bone resorption. So that's the function of your biphosphonates. Then you have methamycin. So methamycin is a cytotoxic antibiotic that inhibits bone resorption. Okay, it inhibits bone resorption. So it will lower down the action of your osteoclast. Then we have inorganic phosphates. So they are phosphates. If I give phosphates, calcium would decrease. Then ambulation, talk about that. So ambulation would increase your bone reabsorption, decrease bone resorption. Then oral fluid intake, just to prevent the occurrence of your kidney stones, and then also to excrete your excess calcium. Fiber in the diet. Fiber in the diet will be to address the risk for constipation. Safety precautions because your patient is on neuromuscular depression. Digitalis toxicity if your patient is taking digitalis because again calcium mimics potassium. Then you have cardiac rate and rhythm monitoring, especially if you are now about to administer your calcium prod. Okay, thank you very much for your kind attention.